All right. Good morning, ladies and gentlemen. Thank you so much for your support. This is session 62, and I would like to thank Dr. Graham, Joseph, Ravi, Roy, Selvi, Sylvia, Sriram, and Dr. Stroline. So these are my acknowledgements, and I'm going to present a case. This is about colon cancer screening and some of the technical issues with screening. And this is a 55-year-old woman who came for screening. No major medical problems, no family history, and she has no otherwise healthy with no symptoms. So this is what we see. All right, I think we'll start with Jagdish. What would he do?
Hi, Dr. Rajat. So I just joined. So
this is a 55-year-old woman who comes in for screening, no family history, and you are just in the rectum. And she tells you that she took the PrEP, she took the split dose, and the moment you go into the rectum, this is what you see. What would you do? What do you see? What are your thoughts? And what would you do?
The bowel preparation is extremely poor. If we are proceeding with the bowel cancer screening, we should not be doing the scope at all. I would ask her whether she wants to proceed, or whether we can hold off, and then we can do with some other day with a good preparation. I will ask her whether she really took the PrEP. If not, then probably I will add on Dalcolax and some more bowel preparation, maybe 5 liters, like 3+2. Yeah. And if she wants to proceed, I will try to wash as much as possible. But I would tell her that she may need a repeat scope in shorter duration, like 6 to 12 months time.
All right. The thing is, she flew in she changed 2 flights, and she came all the way from Alaska. So does it change?
Yeah.
And your next appointment is about 3 months down the road. That's what is happening right now.
Okay. In that case, then I will try to clean as much as possible, and then proceed with the scope. Irrigate the colon. Will take some time. We'll tell her that the procedure is going to take a bit longer.
Okay, that's fair enough.
Yeah, we do it under sedation most of the time. So we sometimes have the luxury of talking to the patient, like if they're awake.
Okay. All right. Roy, what do you do?
I think the concern is that if you have to do an extensive polypectomy or EMR, this could cause a fire hazard. So, and then if there's a perforation, this brings the potential for a colostomy. So this is, safety has to come first. So, and if you have given her the instruction to do the right bowel preparation and she doesn't do it, unfortunately, shit happens.
Okay.
So reschedule.
All right.
But you need to you should be able to schedule within the same week if they come from far away.
Okay.
But suppose you do polypectomy EMR and then there's something bad and there's a methane in there, then you're in bigger problem.
Right. Let me hear what Selvi would do and Sylvia would do.
Sure, Raju. So I always, unless there's, I never abort a procedure in the rectum. So I've been surprised. I agree that the bowel prep is poor, but I would proceed. I would see how far I could get, and I would do lavage as much as possible, and suction out as much as possible, and then, you know, complete the exam, and at least give her that shot.
Okay. So Selvi, I appreciate you making that point of going a little bit up and seeing what else is happening, because we are still in the rectum, and it's possible that this is the something that is limited to the rectum, but the rest of the colon could be fine. I think we have seen those cases. I think it's a good thought to have for the sake of fellows. And let me hear what Sylvia and Joseph would do.
I fully agree that this is a poor bowel prep, and for screening colonoscopy, we would like to have at least 7. And if we score this as 1, we don't get it finally. But I fully agree with Selvi. In practice, I would never stop in the rectum. I will just give the patient a chance. Maybe the segments above are clean enough, so I would wash out and try to go further as far as possible and then decide.
Okay. Joseph?
I agree as well. I have been surprised too. If you go a little bit more proximal, sometimes I notice that the transverse colon is actually not too bad now. Just keep going. That we may have to recognize that by the time we get back to the rectum, you know, I guess it depends. Sometimes they may have actually expelled some of that material, and you actually might get a little bit cleaner rectum. But I agree. At the end of the day, I'll proceed, and then I'll grade it using the Boston Bowel Prep and determine if it's still satisfactory at the end.
Okay.
Can I make a point too?
Yeah.
Okay, now the two approaches that we would consider. The one that Dr. Horuchi does in Japan, this everybody's done under just propofol, is he would go up to the transverse colon or thereabouts and put in a couple liters of saline, and then pull the scope out and then stop the propofol. Patient wake up, go to the bathroom, get rid of all that, and then he does the endoscopy. In the past at the VA, we had a pulse evacuator machine that would clean the colon. So we would just stop and we'd put the machine in and clean the colon. And we published that data, and it works like a charm. And so therefore, patient could be done that day with no difficulty. And since we only use CO2, we don't worry about methane, and it works fine. Now we stopped doing that because the nurses hated it. It took 30 minutes, but it certainly worked well.
Yeah. I'm glad that you made that comment. It's very interesting that what we all do. I'll tell you a few things. Let me go. Let's see. So in Galveston, we actually had a patient bed that is close to a restroom. The way we designed it is, if you pull the curtain, it will almost become a dedicated restroom for that bay. So we designed it because we had a lot of problems in Galveston with poor prep at UTMB. And if the patient came in with this type of prep, we went up to the transverse colon and either pumped go lightly, or in some cases, we actually had Fleet's phosphor soda available, where we just put some more Fleets and some more water and come out, and then bring the patient back and do the procedure. That way we could actually avoid patients clogging up our schedule, because in 2005, when I was there, we almost had 20% poor preps. And that was before we implemented split dose prep and adding some Dulcolax. So I want to, for the sake of our fellows, I actually created this so that they understand, right? When you do the suction, this is the route it takes. It goes up to the red button, and if you press it, then you have the suction. And when you say that you got your suction channel is clogged, this is where it gets clogged as the suction channel takes a turn, almost like 90 degrees behind your red suction button. That's where it gets clogged. And when it happens, we try to pull the suction button and try to see if we can clear it, or maybe put a finger over that suction button valve without the valve, and try to apply more suction and clear it. Those are the tricks we use. And if it doesn't work out, we ask a nurse to back flush so that it's going to clear it up, right? Those are the things we normally do. And when a case like this is happening, what happens is you may have to do a lot of back flush up and down, and it's quite frustrating. So there is a biopsy valve with you could attach the water pump, and you can use that. This is not what we do at Anderson. We basically use a short wide bore needle and put a blunt needle. We attach the water jet to that blunt needle and insert it here. And then this is what it does, right? When you put your foot on the water pump pedal, and then it basically washes at a pretty fast rate with a lot of force. And if there is any debris, it will get cleared. On the other hand, say for example, you have fluid, and then you want to use the suction as well as the needle jet so that you avoid stuff getting stuck there. You could actually press your suction button and also foot pedal. That will actually get rid of the material to clear the stool, especially particulate material. So we came all the way to the cecum, and what do you guys do here?
That's too much.
Do you want to abort, or do you do anything else?
I forgot the first step. First, I use profane language.
Okay, sir. All right. I think Roy was more liberal with the use of that language already. So we basically use the same technique that I talked about. We added a water jet, needle jet to the biopsy port, and then used a repeated flushing and clearing. And you could actually use this technique to clear the debris which you see here, and be able to have a very good clearance. As you can see here, the reason I wanted to show this is something that might be helpful in order to avoid the patient from coming back, right? Fortunately, the colon wall has been cleaned out pretty good. It's not like a thick rim of solid stool that is greasy and stuck. And we were able to get a good exam. And we found some small polyps. Fortunately, nothing that needed electrocautery. And we are able to remove that with a cold snare. And for the purpose of this presentation today, I just removed those cold snares to save the time. So basically what I'm using the water jet pump foot pedal and trying to clear off. And I want to see if I can actually get close to a Boston Bowel prep scale of at least 8. 9 is hard to get, 7 or 8 for sure, and be able to get the job done. Any comments on this, Sylvia or Sylvie?
A quick question. What would be the surveillance interval you recommend in this case?
So in this case, I would actually, the patient had about 3 adenomas, if I remember right. If I have that, I just bring them back at 3 years, not necessarily in 6 months or 3 months down the road. I'm happy with my exam. And the other thing that I do is sometimes what happens is you have this leafy vegetable, like a thin strips that tend to clog your scope as they go up. And if that's the case, if they're settling in one area, I try to use the water jet and try to float off that those particulate material away from the wall and then examine. And once I feel comfortable that I had a good exam, I'm happy to say that I had a good exam.
Okay, thank you.
So here, as you can see here, I'm just trying to show you that the difference between a water jet that comes from the regular channel that is dedicated to water jet versus the channel that goes through the biopsy port. The way the water comes out is different. The regular water jet coming out of the dedicated channel is more forceful, and it causes a lot more spasm of the colon, and it causes more bubbles. On the other hand, if you do it through the suction / biopsy channel, it is a little bit of a bigger bore and more gentler stream, so you can actually have a better exam. It's not going to churn and cause more froth. So here is a small flat lesion that we removed, and I didn't put that video here just for the sake of focusing on how to clean the colon.
Mm-hmm.
So any comments, Roy?
I think it's appropriate, and all of us do this. From time to time, we try our best to help our patient. But just theologically, I think patients also have to have responsibility, right? And number two is that our job is not to become a stool suctioner and cleaner. I mean, yeah, we do it once in a while, but when patients come to me and say, I have a 4-centimeter colon polyp and I ate lunch yesterday, full meal, I said, sorry, come back next time. Because we cannot be doing, the person who wants to have the procedure needs to have responsibility. And it's not our job to be cleaning stool. It's good. I think it's a good example of it. I'm sure we all do it, but it's mostly because patients didn't know. Patients have diabetes and things like that.
Right.
But to come from Alaska and then to have a party and having a steak the day before is like, come on.
Yeah. All right. Selvi, any thoughts?
No, Raju, I think this is, as I said, this is what I would have done also. But I do let the patients know that, it's the best use of my time and expertise is to look for polyps and remove polyps. And it's really a team effort, and the patient needs to come in with, the best possible bowel prep that they can do. And I will do my best possible job as the GI physician for them. So usually if it happens once with a patient and I talk to them after the procedure, it doesn't happen again. So I give everybody kind of the benefit of the doubt for the first time, but after that, if it keeps happening, then, we have a more serious conversation. So I agree with what Roy was saying. I just don't think that this is every once in a while we do it with extenuating circumstances, but not on any kind of a regular basis. And if, that should be reflected in the interval that you bring the patient back, and you let them know, listen, if it was clean, I would have you come back in 10 years, 5 years. And since it wasn't clean, I'm going to have you come back within a year. That's what the guidelines say.
May I have a quick comment? In
Yeah.
this case, I would share with the patient an image I have always on the endoscopy room. I use an image of a flat lesion, and I explain them that with this bowel prep, I take pictures and show them the flat lesion and show them the bowel prep as it is, the level of bowel preparation, to make them clear that these kind of subtle lesions cannot be found under these circumstances. So as Roy said, there is also their responsibility. And maybe I would easily shorten the surveillance interval in such case, because this is a quite young patient and she has no comorbidity, no other risk factors, and missing a flat lesion in this case and having the patient coming back with an post-colonoscopy cancer would not make me happy.
Yeah.
That's just my personal view.
Right. So actually, I want to pose another practical problem for us to think through. So like say, for example, we do this scope and we're not happy with the exam and we bring the patient back, right? Instead of spending an hour and a half to clean the colon, right? So the patient has one exam and then you say, hey, you're not satisfied, you need to bring them back. Whether you put the patient through a colonoscopy or you put the patient through just a proctoscopy, like, you put the scope in and then decided, hey, this is not a good prep. And we come out. And then we bring them back and then we do another exam. Typically what happens is the patient will get billed
Yes, that's correct.
for the procedure where it was not a complete exam. And then he will be billed for the next exam as well. So recently I've been dealing with this issue where I took care of somebody and the patient had a suboptimal prep. We tried to clean and make sure there's nothing, but patient ended up coming back for a repeat exam and the patient got 2 bills. Now the question that we're dealing with is, patient says, no, I should be paying 1 bill and you guys need to write off the second bill. So what do you guys do with that scenario? Because this will happen in everybody's practice, right? You put in and the insurance will probably ask the patient to pay. So what are your thoughts?
I don't know. I don't get this problem too often because I say, if you do this again, I unfortunately cannot do your next colonoscopy.
Okay.
I have a limit. My job is to find flat lesions. Patients are referred to me to have their flat lesions removed. I cannot find something that I cannot see. So if they're not willing to do it, I'm sorry. I cannot do my job. There are many other endoscopists who can do it. Maybe.
Okay.
If you've seen some of the completely flat SSA, even with the perfect bowel prep, it's very hard. So if they come in for like possible SPS and their bowel prep is not perfect, is an impossibility. And when something bad happens, they never remember that it was their bowel prep. They always remember it's the doctor. So, no, thank you.
Dr. Graham, what are your thoughts?
About being rebuilt?
Yeah. How do people deal with that? What's right, what's wrong? Because at the end of the day, what happens is when a patient comes in, there is for a visit, whether the procedure is successful or not. There are so many people spending their time providing the care, right? Whether it's putting an IV, taking them to the room, procedure done, sedation given, scope cleaned out again. So there is so much of effort.
Yeah, there are costs, there's no question about that. So, I mean, there should be some charge. It depends kind of what the unit charges, if they charge $600 or they charge $6,000.
Right.
Makes a big difference. So I think that if they charge a big amount, they should give them a reasonable discount. If they charge a small amount, then it's not necessary.
Right.
I mean, just a practical thing. Now, in Texas, you can always look at their eyes before you start the procedure.
Mhm.
Right.
Because if their eyes are not blue, they're full of it.
Yeah. Actually, it's very interesting. The problem that we deal with is not necessarily just the patients, but also suboptimal prep is probably more frequent in non-GI physicians. Actually, I know I don't have data to say, but my personal experience is most of the physicians are working until the day before with a full clinic or a full operating room or a full whatever they do. And they do not necessarily do the prep the way we want. And it's not uncommon. That's what I do see.
What I tell people that, physicians and others that are busy that I know is do what I do. And that is I take nothing but Jello for 3 days. And that you could eat it off my colon.
Okay. All right. So when we come back to the rectum, I think a part of the stool has gone out, like Joseph predicted, because of all the wash that we gave. And then I do see this thing, when I see something like this, I have to keep in mind, when people are coming from far off, it's not easy to say, okay, let's reschedule. But at the same time, it does impact your own schedule, how it is running that day, especially if the patient is the first patient on the schedule. If it's the last patient, it doesn't really matter. If you still have enough stamina to take care of that poor prep or suboptimal prep. And the reason I wanted to bring this case is, to learn about, what people do when the prep is not optimal and what techniques can we employ. And I find that, using this needle jet through the biopsy port does help in getting a nice clean out so that we can at least try our best to take care of the patient, we all think that.
What are those little white things?
I think these are capsule contents,
I
granules.
think so too, enteric-coated thing.
Right. So we all think that, there are so many things go well before the patient comes in. To just share with you, this Friday, my last patient was scheduled for colonoscopy as a direct access. Nobody saw it. Otherwise healthy, no medical problems somebody in early 50s. And the nurse who was registering the patient found out that the patient came in for colonoscopy, has not taken the prep. And she did not know that prep is needed.
My God.
So, you can see the variation, right? In terms of, not taking the prep versus suboptimal prep.
Correct. Yes.
And We all take things for granted that, okay, patients should know this, but,
That is such a nonsense. Colonoscopy has been the standard procedure in the US for more than 10 years. And everybody knows that one of the biggest problem with colonoscopy, the killer of colonoscopy, is the bowel prep. So for somebody to just claim that, oh my God, and you believe that? I don't know about that one, but I wouldn't just believe it. And this is another thing that I often talk to my colleagues is that here we take our job very seriously. We do every single thing we can. And then you have scheduler, you have other people who are helping with the process. And somebody somewhere dropped the ball. And so why is there such a burnout of physicians? Because we are like putting everything else on everything on our shoulders, and other people, oh yeah, we forgot to tell the prep, or oh, we didn't know, whatever. So oh my God, I would say wow. I'm lost. I don't know what to say. This is to come to MD Anderson to have a super duper colonoscopy without the bowel prep. God forbid.
so did you cool down, Roy?
Yeah, this is a cause for getting fired.
Well, if you get it with MD Anderson, you'll never forget, after you pay the bill, you'll never forget to take your prep again.
Yeah.
Yes, that's correct.
This is a big made up story. I'm sorry.
No, I didn't make up the story. I'm just telling you the
No,
fact.
no, I believe your story, but for the patient to be saying that this is all made up.
No, I doubt that, right? Who would take the time to take time off and show up and pay $12 or whatever for your parking and have an assistant to come with you? We cannot take it for granted that everybody would know this. And what happened was when we tried to figure out
Where is your nurse, the scheduling nurse? Have you taken your bowel prep, ma'am or sir?
No,
There's like a check and balances, right?
So the
So
problem
somebody
here is,
doesn't do the job.
right, no. The problem here was she had one telephone number that was her work number, and they left a message on the work number.
Communication problem.
So you can see that, right? And you have to ask yourself, okay, where was the problem? You could say, okay, so many people should take responsibility. First of all, the patient should take responsibility. But at the same time, as simple as not having all the contact numbers in the system, right? It's not uncommon that you try to contact a patient and you don't have that patient's telephone number that you could reach at, right? We have all seen that, Anyhow, so.
But Raju,
Yes.
this, I wish, I'm laughing at what Roy said. I wish this was a one-off, but everybody who is at MD Anderson who's on this call knows that this has happened to them. And it's not the same patient that's going around to each physician. So there are more than one examples of this situation that happens.
Yeah. It probably happens in other places. We cannot really say that, although Roy feels strongly that everybody should know about colon cancer screening.
And what about considering bowel prep as a quality indicator at unit level, at endoscopy unit level? In screening programs, in the ESGE guidelines recommend that less than 10% of the patients should have poor bowel preparation, or more than 90% should have adequate bowel preparation for a screening program to be accredited.
Right. Let me ask, Nizam is here. Nizam.
Yes, sir.
Have you had patients come to your office or place where they said, I didn't know about the colon prep, or it doesn't happen at all?
No, it happens sometimes, and I mean, of course, we don't have any formal studies, but just anecdotally, what I noticed that it's more with the people who have a language barrier. And you know, I remember of a patient who came with the whole prep instructions and everything, of course, given to him in English. He brought all of his papers and the instruction is there, but because of the language barrier, he didn't follow any of the instruction. It became meaningless to him. And you know, so we do face that barrier, and you know, from time to time, we do have a problem with translator. We do not have sometimes the resources available to us, and I do see that problem specifically more commonly. As you know, one of my practice is overwhelmingly Caucasian population still, and say as opposed to my Pearland practice, which is a lot more diverse, and we do have Spanish-speaking employees all the time, and majority of them are Spanish-speaking, so I have less problem. But in the other office, where still, you know, majority of the patient as well as the overwhelming number of employees are non-Spanish speaking, I do, you know, come across that problem from time to time. Yes.
Yeah, it's a problem. Unfortunately, I think, you know, smaller problem.
Correct.
And maybe from here, Sylvia could take a little bit of time to summarize what we learned.
We have already used a couple of times the problem-solving decisional framework. Please, Roy, feel free to correct me if I'm doing it not yet. I'm not yet experienced in doing that every day. But in my opinion, in this case, we should first start with a context and the key information. It's about a 55-year-old woman who undergoes primary colonoscopy screening. She has no comorbidity and no family history, so she's an average risk patient for colorectal cancer. And the most striking finding is the poor bowel preparation immediately after insertion of the scope. And if we compare with our previous experience, we say, well, this kind of bowel preparation is not going to, number one, help me detect adenomas or serrated lesions, increases my risk to miss lesions. And if I'm going to do an endoscopic resection, I will bring my patient, I will probably cause a complication like perforation. So that's the moment when we need to decide, and we always list the possible solutions. Experts are thinking, what am I going to do in this case? First solution would be stop immediately and reschedule the patient with longer bowel preparation and larger volumes. We usually apply a 3 days diet with bisacodyl, add bisacodyl to the regimen, and use pico prep of movi prep or other regimens. And the second solution would be, let's continue, wash out as much as possible. And if it's not going to work, we can still stop, or let's bring the patient back in, let's say, in 1 day or as soon as possible with better bowel preparation. So we list all these solutions and we finally take a decision. And I think for me, in this case, the most important take home is that we should individualize our decision to the patient. maybe this patient who's coming from far away will still prefer to take one night in a hotel and continue the bowel prep and come the next morning for a new colonoscopy. I would definitely explain her that I cannot rule out subtle lesions in this case, and there is a risk that she will come back with cancer. So that being said, I think I would like to thank you all for all the wonderful lessons I have learned along the way and for sharing your experience. Thank you.
I want to take a couple of minutes to thank everybody, and I want to thank Selvi. Selvi has been of great support. I really appreciate Selvi for everything you have supported, even in the midst of pandemic and some setbacks. And I want to thank Roy. I want to thank Sylvia for beautiful commentary. I think it's amazing. You know how to summarize the learning points. And I want to thank Joseph, my colleague, who is passionate about education. And Nizam, thank you for joining. I really appreciate your support and sharing what happens in your practice. And lastly, Zubair and Jaydesh, thank you so much. You've been the source of inspiration. I think this is all, we started at the beginning of the pandemic, keeping the trainees in mind. I hope this has been useful. All right, thank you. Hope you all have a great weekend. Thank you. Bye-bye.
Thank you,
Prof.
Raju.
Raju,
Thanks,
sorry.
Thank you,
everyone.
Dr. Raju.
I
Congratulations.
have a word. Sorry,
Yeah.
Prof. Raju. I'm really thankful for all your effort. I should thank Ravi for introducing me to this course. But it's been a pleasure to interact with people like you, Prof. Roy, Dr. Sylvia, and Dr. Sylvie, Joseph. All of you are world experts in this field. Without this forum, I wouldn't have had access to so much new information, and also a very good inspiration by listening to you. I mean, at this level of expert and such a big caliber, you still take up a lot of time to prepare all these sessions. It's very inspiring. Thank you. I hope, like Zubair said, we can continue this every month, or once in a month or once in 2 months. You can send out the links to us so that we can join in to see the interesting cases, and it will be a refresher for us to when we proceed to do practice as well. Thank you.
Thank you. Thank you again. What I will do is I will hold off for now. And when we restart fresh, and I'll send you a message.
Thanks a
All right.
lot.
Thank you.
Bye-bye.
Okay.
Bye, everyone.
Bye, everyone.
One TSG meeting,